So hopefully you know by now that your kidneys help filter your blood and your plasma. Otherwise, I'm not doing a good job. Yeah, that's the main function of the kidney. And to do that, it has to maintain a certain blood pressure. And if your blood pressure drops, then your kidneys will freak out and try and raise that blood pressure back up. It does this via the RAAS system. The RAAS system. Now the RAAS system helps you raise your blood pressure back up. And it does this by reabsorbing salt and water. And by reabsorbing salt and water, you get more fluid, you get more pressure, helps raise your blood pressure back up. All right, how does it do this? Well, let's just draw out our nephron. Here's your glomerulus, proximal convoluted tubule, right? Thin descending limb, thick ascending limb, distal convoluted tubule, and your collecting duct. It should be kind of sac in nature by now. And blood and plasma is fed to your nephron via your glomerulus. So here's your afferent arteriole. And your arteriole will eventually become capillaries. A bundle of capillaries called your glomerulus. Glomerulus. All right, afferent arteriole. And it'll feed plasma through. And anything that doesn't get through will leave via the efferent arteriole. Hopefully no problems there. That efferent arteriole will eventually become your peritubular capillary. And if your body wants to reabsorb anything like amino acid glucose, it'll just send it right back in your peritubular capillary. Go back to your body. Simple as that, simple as pie. So how does the RAAS system work? You sense that low blood pressure, you want to raise it back up. How does it work? Well, there's some very, very important cells right in this region. Right in this region. So let's just blow it up, magnify it. So here's your glomerulus with your proximal convoluted tubule. Being fed by your afferent arteriole, making your glomerulus, which eventually becomes your efferent arteriole, right? So that's that part. And then right up here, here's your distal convoluted tubule, okay? So your distal convoluted tubule. Now there are special cells of your afferent arteriole called juxtaglomerular cells. Special cells of your afferent arteriole. And juxta means next to or near glomerulus. So these are cells near the glomerulus, perfect name. And they will sense decrease in pressure, so decrease in blood pressure. And when they sense that, they release an enzyme called renin. They release an enzyme called renin. All right, renin. And this renin will go through, not get filtered through, and continue onto your body. All right. And renin is the first part of our system. So it senses a decrease in blood pressure, releases renin to raise that blood pressure back up. Another activator of renin is your sympathetic pathway. Sympathetic via beta 1 receptor. In sympathetic, remember that's your fight or flight. Don't you get high blood pressure? Don't you get your heart beating, your tachycardic, all that stuff? Well, how do you think you get that high blood pressure? One of the mechanisms is through this, activating your RAAS system. So I'll just write B1, very important. So those are your juxtaglomerular cells. Now how about your distal convoluted tubule? Well, your distal convoluted tubules have special cells called your macula densa. Macula densa. And your macula densa senses low sodium. And when it senses low sodium, what do you think it will release? It will release renin. It will release renin. And renin will activate the RAAS system and raise your sodium, reabsorb sodium. We call the culmination of this the juxtaglomerular apparatus. The apparatus near your glomerular. What a fitting name. And that activates your RAAS system to raise back your blood pressure. Let's see how renin does that. So you release renin into your blood, and it'll meet a protein called angiotensinogen. Where does that come from? Well, where do most proteins come from? It comes from your liver, all right? So your liver will just pump out angiotensinogen and it'll float around until it hits the enzyme renin. And when it hits the enzyme renin, it becomes angiotensin I. So it gets converted to angiotensin I. And now that will float around in your blood until it goes to your lungs. And in your lungs, you have an enzyme called angiotensin converting enzyme, or ACE. What a great name. And you can guess what that does. Converts angiotensin I into angiotensin II. And angiotensin II is probably the most important thing in the whole RAAS system. All right, can you think of what angiotensin II does? We talked about one of the functions, hopefully you remember. Angiotensin II, doesn't that work on the sodium pump in your PCT? Increase your sodium pump in your PCT, helps reabsorb that sodium. Doesn't angiotensin II also increases aldosterone? You know what I'm going to ask you. What does aldosterone do? Doesn't that work on the ENAC channels of your collecting duct? And that's your pumps in sodium at the expense of H plus and K plus. Correct? Angiotensin II also creates the release of ADH. You know, I'm going to ask you, what does ADH do? Works on your V2 receptors to increase aquaporin channels, increase the absorption of water. Hopefully it is all like a recap, yeah? We're all bringing it back together. And if that's not enough, it stimulates thirst. Stimulate thirst. That way you drink more, get more volume. It causes vasoconstriction. That increases your blood pressure. In particular, it can constrict the efferent. Constrict efferent. Constrict the efferent. What do you think that does in terms of GFR? Doesn't that cause a buildup of fluid and increase GFR? We talked about that in our previous video. Why does it do that? Well, a lot of times when you have a decrease in blood pressure, your kidneys aren't getting the fluid it needs. And so by constricting this and increasing GFR, it gets that fluid. All right, so angiotensin II is incredibly important. I'm gonna put a star. Don't mind if I do, I'm gonna put a star right there. And that is your RAAS system. Now you're probably thinking, well, there has to be some sort of regulator of this. You can't just let this go hog wild. You can't just keep reabsorbing sodium and water. We'll get bloated, we'll balloon up and explode. And there is a counter-regulatory system. All that fluid will eventually hit your heart. So I'll just draw your heart like this. Here's your two atrium, and then your two ventricles. That's the simplest way I can think of it. Fluid will go into your heart, hit your atrium, hit your ventricle, and stretch them. And when your heart gets full of fluid and stretches, it's like, whoa, it freaked out. It knows there's too much fluid. It's fluid overloaded. And your atrium will release a hormone called atrial natriuretic peptide. All right. Natriuretic means you're trying to get rid of sodium. So it's a peptide released from your atrium that helps you get rid of sodium. And that kind of reduces the fluid. Your ventricles will stretch, freak out, and release something called brain natriuretic peptide. Unfortunately, it's not called ventricular natriuretic peptide. They call it brain natriuretic peptide because it was first isolated in pig brains. All right, that's a little aside, but just know it's called BNP. This is another drug that helps you release some of that sodium. Release some of that sodium. So, all right, it promotes sodium loss. That way you lose some of that fluid. So I'll circle that. That's the main function. It can also relax your vessels, via cyclic GMP. For example, relaxes this. And that way you have increased GFR, increased filtration, and you pee more. And that way you also release some of the sodium. Some physio tie-in, anytime someone has heart failure, one of the first labs we draw is BNP. Because in heart failure, you get fluid overloaded. Your heart can't pump the fluid out, and so you would imagine your heart would stretch, and you would imagine your heart would release a lot of BNP. Your BNP will be raised in heart failure, and that's exactly what we see. So, all right, BNP raised in heart failure. All right, that's a lot. That's very cluttered. Let's try and clear the board, all right? So hopefully you got most of this down. The RAAS system raises your blood pressure. That is what it does. You can imagine then, in people with high blood pressure, we might want to give drugs that work on the system, kind of lower that blood pressure. And that's exactly what we do. So we have some drugs that work on the system and try and lower the blood pressure. One of the big ones is aldosterone. And this is a direct Renin inhibitor. What does that do? Well, it has a pathway right here, don't I? So if you block Renin, what does that do? If you block the enzyme Renin, what does that do? All right, so a lot of questions I've seen is they'll be talking about giving this drug and then ask you what happens, what's the mechanism. It stops the conversion of angiotensinogen to angiotensin I. Got that? Side effects? You can have too much a good thing. You can lower your blood pressure too much and you get hypotension. That one's kind of self-explanatory. You can also have hyperkalemia. Hawaii. One of the functions, I wrote it down here, you release aldosterone that works on your ENAC, takes in sodium and pumps out things like hydrogen and potassium. If you don't do that and you don't take in sodium, then you never pump out things like hydrogen, things like potassium. So you hold on to potassium, you get that hyperkalemia. Another huge drug that we use all the time is ACE inhibitors. ACE inhibitors. If you block out ACE, what do you think that does? Have the pathway Renal out. So if you block ACE, you stop the conversion of angiotensin I to angiotensin II. You stop that conversion in your lungs. You don't get angiotensin II. That's like the big player, right? So you don't get that, then you really throw a wrench in this pathway. This is really good, especially in diabetic patients. Why is that? We said that angiotensin II constricts your efferent, raises that GFR. Well, if you're diabetic and you have a lot of sugar, which is toxic to your kidneys, then you don't want to raise GFR. You don't want all that sugar to hit your kidneys, right? So if we block angiotensin II from doing that, we relax the efferent, reduce GFR, all right? Kind of reduce the strain on the kidney. All right, so it's great for diabetic patients. It's also great for patients that are post-MI or have heart disease. So I'll write post-MI. Why is that? It stops heart remodeling. So, all right, stops heart remodeling. Because you really block this big player. You reduce the amount of fluid in your heart, reduce the amount of strain in your heart, and so it kind of stops heart remodel. All right, these are two big facts that you gotta know. Especially diabetes. They might ask you, a patient has hypertension and diabetes, what's the best bang for your buck in terms of pharmaceuticals? Definitely ACE inhibitors. Definitely ACE inhibitors. Been asked that a ton of times. Some side effects. ACE is an enzyme that works in the RAAS system and also works in the kallikrein system. This is an inflammatory system, all right, so it's completely different. And ACE helps break down bradykinin. And if you block that, then you don't break it down. Bradykinin will start to build and build. And bradykinin is a vasodilator. So some side effects of using ACE inhibitors, if you let bradykinin build and build, is that you're gonna have angioedema. You're gonna have so much vasodilation, your mouth's gonna swell, your face is gonna swell, your eyes are gonna swell. So vasodilation or edema is a big one, so right, edema. Also, when bradykinin builds up in your lungs, you get a cough. You get a constant dry cough. Always ask. Patient, 50-year-old man has hypertension, given a drug, starts to develop a cough. Simple as that. All right, so very simple. In fact, any old patient that has like this dry persistent cough, always look at the meds. That's not just for the step, that's for like your life moving forward. That's so commonly seen in the worst, is unbelievable. So cough is a huge one. I'm gonna put a star next to it. One thing they also want you to know is it is a teratogen. It blocks the RAAS system working in your kidneys, but if you're pregnant, it can also block the RAAS of your fetus's kidneys. So it can cause renal malformation, renal teratogen. That's one you gotta know too. All right, so that's another one that's commonly asked. Can you think of a step-like question where they might ask that? Pause the video, see if you can. Commonly asked, they'll talk about a pregnant lady who's taking a drug for hypertension, and then starts to develop things like oligohydramnios. And they might ask you, why? Because they were given this drug and it basically wiped out the baby's kidney function, and the baby wasn't able to pee and develop oligohydramnios, Potter syndrome, all that stuff. All right, so that's one of the ways they can ask that. And one last drug I want to talk about is going to be your Angiotensin II receptor blockers. Name gives it away. It's something that blocks the receptor for angiotensin II. By blocking it, you don't have angiotensin II activity. What do you think the side effects are going to be? Do you think you're going to have that cough? Do you think you're going to have that angioedema? Why would you? Right? It has nothing to do with ACE. Right? It has nothing to do with the lungs. It has nothing to do with this whole bradykinin system. All right, so you have reduced side effects of things like cough and angioedema. All right. Those are the drugs that work on the RAAS system. That's your RAAS system. And before we finish this whole thing, I just want to take some time to talk about the other hormone functions of your kidneys. The other hormone functions of your kidneys. Your kidneys do a ton of things, and one of them is producing hormones. We talked about some here. We talked about some earlier. We said your PCT released what hormone? If you said 1-alpha hydroxylase, you'd be right. What does that do again? Activate vitamin D. Some other very important ones that your PCT releases, or PCT, is dopamine. Dopamine does a ton of things in a ton of different places, but here it can cause vasodilation. And then one we touched upon, not specific to your PCT, but all over your kidneys, is prostaglandins. And what do prostaglandins do again? They vasodilate the afferent. Alright, so let's draw it out. Here's the glomerulus, proximal convoluted tubule, being fed by afferent arteriole. Here's your glomerulus. Anything that's left goes out your efferent arteriole, and that becomes your peritubular capillary, right? And by vasodilating your afferent arteriole, you increase GFR. And what happens if you take NSAIDs? Well, then you won't dilate this. You would decrease GFR. NSAIDs decrease GFR. And that's why NSAIDs can harm your kidneys. One you always gotta remember. And the last one, the last hormone I want to talk about today, and we'll be all done, EPO. EPO is what's released in chronic hypoxia, like those that train at high altitudes. The EPO is also a drug that blood dopers take for like the Tour de France. Yeah, it increases your red blood cells, and by increasing your red blood cells, you carry more oxygen. You carry more oxygen, you can deliver it to your muscles more. EPO increases red blood cells. And where are they released? In your kidneys. This one's always asked, in your peritubular capillaries. Releases EPO. So right, peritubular capillaries. Always comes as like a curveball. They'll talk about someone who's at high altitudes, chronic hypoxia, increased red blood cells, and you're thinking EPO. All right, they might ask me, you know, some mechanism, some pathophys, and then all of a sudden they say, where does it come from? And you're like, you're freaking out, you don't really remember. Just try and recall it comes from the peritubular capillaries of your kidneys. And if you can do that, you'll be golden, all right? So that does it for the hormonal function of your kidney. That does it for your RAAS system. Hope you enjoyed the video. Thanks.